The U.S. spends more than any other high-income country on healthcare, yet we have little to show for it. Life expectancy, obesity, infant mortality. You name the measure, we're near the bottom.
People have been saying that for, 20, 30 years, and there hasn't been a real solution. We need something that's completely different.
A group of nurses in Baltimore has a bold plan. Rather than treat people after they're sick, bring preventive primary care to everybody, no matter their age, income, or insurance, and deliver it right to people's doors. Today, inside an ambitious attempt to open a new front door to primary care in America and the barriers that could derail this dream. From the studio at the Leonard Davis Institute at the University of Pennsylvania, I'm Dan Gorenstein. This is Tradeoffs.
Just take some deep breaths.
72-year-old Edward Murray is getting his blood pressure checked.
Get a little tight, okay?
Making sure his new dose of medication is doing its job. Michelle, a nursing student, loosens the cuff and watches the numbers.
I got 130 over 86. How does that sound to you?
Sound pretty good. Yeah. Sound better than 180 over something. Because it was up there.
Michelle jots down the results on a slip of paper.
And then I'm writing down today's date and then the time.
Hands it to Edward, who plans to bring the reading to his next doctor's visit.
I'm very happy to have y'all here.
What's happening here in East Baltimore on a Tuesday in late April might sound mundane, but actually, it's radical.
We're trying to turn primary care on its head and deliver it in a completely different way.
Sarah Szanton is the dean of the Johns Hopkins School of Nursing and the woman behind this bold initiative known as Neighborhood Nursing. It's a partnership with 3 other local nursing schools, Morgan State, Coppin State, and the University of Maryland. What makes their approach unique, says Sarah, is both who it's for and where it's happening. It's happening where people live. In this pilot phase, they're in the lobbies of 3 apartment buildings in Johnston Square, one of Baltimore's most marginalized neighborhoods. And this care, it's for everyone, sick and healthy, rich and poor, whether they have Medicaid, Medicare, a private plan, or no insurance at all.
An all-in approach where everybody has access to primary care at least once a year, and not just focused on the people who happen to come into a clinic.
That means a nurse and a community health worker visiting with people wherever they live, checking on vital signs, medications, vaccinations, and people's social needs, their hunger, their housing, their safety. Keeping people healthy where they can, and when they can't, connecting them to the larger medical and social service systems.
If this works, there'll be fewer emergency room visits, fewer 911 calls, fewer nursing home admissions, and it'll save money because it'll be so much more preventive.
This is not what primary care looks like in America today, says Asaf Bitton.
It's pretty much night and day.
Asaf is a primary care doc and director of Ariadne Labs, part of the Harvard School of Public Health. He describes what our country currently has as a sick care system.
Basically, we in the U.S. are okay with you having a preventable illness until and if you literally collapse in front of us. At the craziest moment, we're going to take you into the hospital and put you in the ICU for a month and try to paste over the social ills that exist and then send you right back out to where it started and pretend that that was good health care.
Compared to other wealthy countries, Asaf says, the U.S. spends much less on its primary care, about 5 cents out of every healthcare dollar. And we skimp on social supports like food and housing, too. Take even a sliver of the money we spend on all that sick care, he says, and shift it further upstream, invest in more primary care, and Asaf believes, just like Sarah Szanton does, America could prevent a lot of suffering and inequity, and spend less money. Some of the most convincing evidence to prove that, he says, comes from Costa Rica.
Buenas. ¿Cómo está, Fabiola?
The small Central American nation of 5 million people has pioneered a near countrywide version of neighborhood nursing. Teams of health workers are assigned to care for about 5,000 people in a given area. From urban cities to banana farms to remote villages reachable only by boat.
Each person has access to a community health worker who sees them at least once a year in their house. It's basically like a front door into the health system.
Costa Rica developed this as a solution to lots of healthcare needs going unmet, especially in poor areas. Asaf has traveled to Costa Rica to study its system, and there's one trip that always stands out.
You know, when I tell it to people in the U.S. and they're like, oh, that can't be actually true.
A local care team took him to see a patient who was home after being treated for a stroke in the hospital. The patient was a poor migrant worker from Nicaragua.
I said, so where are we going? And they're like, we'll just go wherever the iPad tells us that this person is living.
The community health worker pulled up the patient's entire health record on their iPad, which even included how to get into the patient's house.
When you approach it, it's down this part of the alley. Don't go in the front door because there's a really mean dog who will bite you. Go around the other entrance to the back door and knock 3 times, and then they'll let you in.
And that is exactly what happened.
It was an astounding moment. Here you have a person living on the social margins who might be excluded from other societies. But in this situation, you have a sophisticated system that's meeting her needs comprehensively and connecting her to the services that she'll need as she recovers from a life-threatening illness.
Asaf explains that getting inside of people's homes helps teams see if someone's drinking water is clean or if they have enough to eat. It helps them adapt care to the realities of people's actual lives. Costa Rica has been delivering preventive care door to door nationwide for about 30 years now. Communicable diseases like hepatitis and tuberculosis have fallen by 94%. They've cut deaths from chronic conditions like diabetes and heart disease and improved disparities too. And the country has achieved all of this while spending 1/11 of what America spends per person on healthcare.
It's an incredibly efficient and effective system. And beyond that, it's also beautifully humane. I mean, every person is counted, every person matters, and every person is reached out to. And I find that incredible.
Other countries like Sri Lanka and Brazil have taken pages out of Costa Rica's playbook. The question that no one in the U.S. has tried to answer until now:
What if we tried to do Costa Rica here?
Sarah Szanton is optimistic that this idea that's blossomed in Costa Rica can also take root in a land as different as Baltimore, Maryland, with a healthcare system as broken as ours. She sees the U.S. grappling with the same core challenges that Costa Rica had. Patients struggling to get care, emergency rooms overflowing, nurses and doctors in short supply.
It's a little bit like if 10% of our houses were on fire. We would say we don't have enough firefighters. But really what you need to do is prevent fires, which we do in general. But we've never done that for medical care in this country.
It's super early days, says Sarah. The neighborhood nursing team has only been serving a tiny corner of Baltimore for a few months now, but she's already seen 2 promising signs of progress. First, the team is spotting what Sarah might call fire hazards, and they've been able to snuff a bunch of them out. Pretty easy. Simple stuff like giving Edward Murray, the man from the lobby, a way to monitor his blood pressure when he had no cuff at home, and more serious needs, like a woman who'd spent almost an entire year without a working wheelchair, risking both her health and her safety.
The brakes didn't work on the wheelchair. One of the arm things kept falling off.
Terry Lindsay is the team's community health worker whose job is to help address patients' social needs. He got on the case. Terry took a trip down to the woman's doctor's office and politely, but firmly, pushed for answers.
I found out that the individual's paperwork was never submitted. So I said, well, is there any way you can send it? They said, yeah, they're going to get on it today.
1 week later, a brand new wheelchair arrived. The second promising sign that Sarah sees, real buy-in, both from individuals and the Johnston Square neighborhood.
One time I saw this young guy coming through the lobby, and for lack of better terminology, he looked like a thug, right? Had his pants hanging low, all tatted up. I said, man, come get your blood pressure checked. He said, ah. I said, what you doing right now? He said, I'm waiting for a friend, right? I said, well, come on over while you waiting. He came and got his blood pressure checked, right? 2 weeks later, he was back in and checked again.
Terry chalks up the man's return to a combination of convenience, comfort, and need, the same things that drew people in Costa Rica out of the shadows and into the healthcare system.
First couple of weeks we showed up, it's like, who are they? And now it's to the point where people say, are you coming back next week? People now open up their door to their homes. Say, come on in, sit down, talk.
Despite the signs of fertile ground, Sarah is clear. This idea she's hoping to transplant from Costa Rica is still a very fragile seedling.
There's still so much to work out. How to get people's data into the larger primary care system. How do we measure outcomes that matter to people and the stakeholders who are paying into the system?
All details that could be deal breakers. On top of those questions, experts say several much larger questions loom over the fate of this project and, more broadly, the future of primary care in America. We get into those after the break.
Curious about the strategies behind successful leadership in the age of AI? Amazon Web Services Conversations with Leaders podcast presents candid discussions with top executives, delving into their experiences, insights, and perspectives on navigating challenges and driving innovation in today's business landscape. Join the conversation and subscribe today. Available on all major podcast platforms.
Welcome back. Before the break, we heard how neighborhood nursing hopes to bring basic primary care to every single person's doorstep, no matter their age, income, or insurance. But despite some signs of early progress, it's impossible to avoid asking the bigger question. Can this bold idea survive past the pilot stage? Our senior reporter, Leslie Walker, posed that question to 10 outside experts. Hey, Leslie, how are you?
Hey, Dan, doing pretty well. And if I had to boil down those 10 conversations with folks across the board, they like this idea.
This is extremely innovative.
I love this.
I think it's a great idea.
But they're also clear this is going to be a tough hill for neighborhood nursing to climb.
What they are trying to do is incredibly hard.
It's really so complex.
There are lots of ways in which this can fail.
Experts' concerns really come down to 3 big questions. But I've also got a couple rays of hope in here for you, Dan. Some reasons that experts also say this just might, maybe, possibly work.
Excellent. I do enjoy a little side of sunshine with my plate of gloom, Leslie. So let's dive in. What's the first cause for concern?
No surprise here. Everyone's mind went straight to money. Who's going to pay for this whole thing? And here's why the payment puzzle for neighborhood nursing is especially tough. Dawn Alley, who spent 7 years over at the Centers for Medicare and Medicaid Services trying to figure out how to fund innovations just like this, had me do a really helpful thought experiment. I want to run it by you. Grab your abacus, Gorenstein.
Wow.
You don't
have a pen.
Oh, okay.
I've got my pen on me.
I thought you were a little older, but pen's fine. So start by thinking about who neighborhood nursing wants to serve. Now, a lot of healthcare innovations target one group, right? Older people or folks in heart failure. Neighborhood nursing, they're trying to serve literally every single person. Now, for each of those people, Dan, ask yourself, who's got a financial interest in seeing that person's health improve?
I mean, in most cases, we're talking about insurers, right?
Yeah, they're the ones most likely to fund some piece of this program. Now, Don says, tally all those paying parties up, from Medicare and Medicaid plans to private insurers.
If you try to map this out for a county, you're probably talking about minimum 50 different entities.
50, Leslie? 50 different insurers in every county? Really?
That's right. Each who might want to pay the nursing team differently, use different contracts, different metrics, different incentives, define success, Dan, differently.
Right. This is why these universal programs are so hard to pull off. They sound good, but operationalizing them means working with so many different people. It's really tough.
And the main reason here that insurers would even sign on is because this could save them money. But retired healthcare executive Tom Mullen told me, without any evidence so far in the U.S., neighborhood nursing ends up looking like a pretty risky bet.
If it doesn't work, you're SOL,
That's shit out of luck, Dan. Money's gone.
Thank you for that translation, Leslie.
Anytime. Now here comes your ray of sunshine, Dan. Get those sunglasses on. Federal and state health officials are, as we speak, trying to dream up ways to incentivize more primary care innovation with an eye towards slowing down how much we all spend. One example out of several, actually, is by the end of this year, the feds are going to pick up to 8 states for this decade-long experiment that's going to attempt to cap how fast healthcare spending can grow statewide.
Wait, so slow down here for a second, Leslie. You mean across all insurers, all hospitals, cap how much their costs can rise at, for example, let's say 3% a year?
That's the idea. And this experiment, Dan, it's also going to spell out what percent of all that spending has to go toward primary care.
I see. So a program like neighborhood nursing, in theory, could be super attractive to these states because the idea behind neighborhood nursing, again, is more primary care improves health and can keep costs down. Just the kind of thing they're looking to do.
Exactly.
Okay, so that's the payment puzzle, Leslie, that neighborhood nursing has to navigate. What's the next big question your experts had?
Next one, can these teams of nurses and community health workers effectively connect folks to all the other health and social supports they're probably going to need?
They are delivering care, but they're not delivering the full suite. And so they have to be part of something bigger.
Chris Koller is the president of the healthcare philanthropy, the Milbank Memorial Fund, and a co-author of a landmark national report about how to fix primary care in America. And his point, Dan, is that as these teams get inside people's homes, they're going to uncover needs for everything from specialists and medications to food stamps, mold removal.
Yeah, I mean, these teams effectively are opening up a new front door to our larger health and social services system. And the question is, what's waiting for them on the other side?
Yeah, and there's real reason to worry that nice-looking new door might lead to some pretty frustrating dead ends for folks. For example, neighborhood nursing might not care what insurance people have, but doctors do.
Because the doctors get paid by those insurance companies. And I know finding those docs is a big part of the challenge. When I was in Baltimore talking with people, everybody agreed that there's this huge need for mental health and addiction services, but not enough providers to meet that demand.
And those kinds of capacity constraints you're talking about there, Dan, are another reason experts are concerned about where this front door is going to lead. That's a weakness in Costa Rica's system, too, where people wait months to see specialists or get surgeries.
I still have my sunglasses in my pocket. Can I put them on? Is there any reason for optimism here before we get to this final question of yours?
I would not put them fully on for this one. But I will say, if anyone's proven good at navigating our confusing, overstretched systems of care in this country, it's community health workers like Terry from the first half, who neighborhood nursing has got on the case. But there's no sugarcoating the fact that some folks are very likely just not going to be able to get what they need.
Okay, so what's the third and final question?
I'll keep this one short. Can this program scale beyond Baltimore? It's a question Sarah Szanton's thinking about a lot.
And why is that?
About 15 years ago, she launched this other program designed to tweak older people's homes, like adding handrails, making showers safer, so folks could stay instead of moving into nursing homes. Multiple trials showed the program improves people's health and saves actually a ton of money. But even though it's been around for more than a decade, expanded to more than 20 states, it's only served about 10,000 people. Almost no juice for the squeeze.
So why does Sarah think this time's going to work?
Well, she said she's going straight to the money and the power.
Who needs to buy into this to want to scale it? And what do they need to make that happen?
In other words, she's going to insurers, policymakers, some hospitals, trying to get them on board early. And so far, she says she's getting a warm reception.
All right, so you've given us some reasons for both a lot of caution and a hint of optimism. There's one more break in the clouds, though, that I wanted to share with you, Leslie, based on my time in Baltimore back in April.
Oh, okay. A sunshine surprise. Love it.
We're actually walking down the street at the moment if you want to take a walk around the neighborhood.
That afternoon, Regina Hammond, a longtime resident of Johnston Square, she invited me on this walking group. Now, they got some help organizing it from Sarah's team, but it was spearheaded by Regina and some of her neighbors.
Some other people in the neighborhood, they walk other days too now as a result of meeting each other at the walking group.
The reason there's some sunshine here, Leslie, is that both these folks and the neighborhood nursing team told me having the program around is kind of like putting being healthy more on the map. For example, a woman with depression, she joined the group, helping her feel a little bit better. A man discovered that there's an urban garden a few blocks away after he did one of these walks, and that made him feel better about where he lived. And to me, this was a sign, right? Like a small sign for sure, but a sign that at least a handful of people are taking a program that was started by these nurses, inspired by a country 2,000 miles away, and starting to make it their own.
And I'm so glad you brought this up, Dan, because that's part of Sarah's ultimate vision here, too. She's not only trying to improve the health of individuals, but also empower communities to create happier, healthier places to live, whatever that means to them.
Health is different for everybody, and health isn't just being free from suffering. It's also experiencing joy and being able to participate meaningfully in society. And if people have their social needs met and their medical needs met, they'll be able to do that.
Leslie Walker, a pleasure working with you on this story.
Likewise, Dan.
By early 2025, neighborhood nursing aims to start delivering care door to door in at least 4 neighborhoods, 2 in Baltimore, 1 in the suburbs, and 1 outside the city. We plan to follow the program as it looks to scale. If you've got questions about what they're up to, reach out at info@tradeoffs.org. That's info@tradeoffs.org. I'm Dan Gorenstein. This is Tradeoffs.
If you enjoyed today's episode of Tradeoffs, don't keep it to yourself. Tell someone else about it. Friend, colleague, family member. Better still, leave a rating or a review wherever you subscribe to us. The NPR app, Apple Podcasts, Spotify, wherever. The Tradeoffs team is producers Ryan Levy and Alex Olgin, editors Kate Cahan and Deborah Franklin, executive director Jessica Silverman, marketing director Catherine Dougal, audience engagement lead Shannon Crane, with help from Kate Seepy, Kelly Osmondson, and Cedric Wilson, sound designer Andrew Perella, executive editor Dan Gorenstein, and senior producer Leslie Walker. The Tradeoffs theme song was composed by Ty Sitterman, with additional music this episode from Blue Dot Sessions and Epidemic Sound. Tradeoffs coverage of primary care is supported in part by the Commonwealth Fund. Additional thanks to Natalia Baroline, Shule Garovich, Ann Greiner, Ashley Gresh, Vincent Guillermo Ramos, Seiji Hayashi, Kevin Klemchek, Kennedy McDaniel, Madeline Pesic, Tiffany Reiser, Lisa Stambulis, and the members of the Johnston Square Walking Group. Thanks also to Uncared For, hosted by Soo Chin Pak, a production by Lemonada Media in partnership with the Commonwealth Fund. Thanks also to all our listeners who help to support our work, including Vanessa Frank, Logan Kelly, and Marilyn Bartlett. Our media partner is Side Effects Public Media based at WFYI. Tradeoffs is supported by the Robert Wood Johnson Foundation, Arnold Ventures, the Gordon and Betty Moore Foundation, the Sozoze Foundation, Just Trust, West Health, the California Healthcare Foundation, the Leonard Davis Institute at the University of Pennsylvania, and the National Institute for Healthcare Management Foundation. Our financial supporters are not involved in any decisions about our journalism. The views expressed in this episode are those of the individuals and not those of Tradeoff staff, advisors, or funders.
Imagine the softest sheets you've ever felt. Now imagine them getting even softer over time. That's what you'll feel with Boll & Branch's organic cotton sheets. In a recent customer survey, 96% replied that Boll & Branch sheets get softer with every wash. Start getting your best night's sleep in these sheets that get softer and softer for years to come. Try their sheets with a 30-night guarantee. Plus, get 15% off your first order at bollandbranch.com. Code BUTTERY. Exclusions apply. See site for details.